Good morning, good afternoon. I'm Natasha Muscat, and on behalf of the WHO Regional Office for Europe, I'm delighted to welcome you all to this special consultation of the Pan-European Commission on Climate and Health, where today we will be focusing on health systems. A warm welcome to all our online participants, especially our Chief Scientific Advisor and 11 esteemed commissioners joining us today. Thank you. Ladies and gentlemen, the purpose of today's consultation is for the Commission to hear directly from senior health systems experts, policymakers, hospital leaders, medical associations, and supply chain actors. We will take a deeper dive into the internal governance, strategic priorities, and operational approaches that health systems need to drive climate change effectively. Climate change is among the most pressing and systemic challenges threatening health service delivery, health equity, and resilience, while adding or even amplifying other stresses: health workforce shortages, antimicrobial resistance, non-communicable diseases, and persistent inequities all demand urgent attention. Climate and sustainability action cannot be treated in isolation. They must be embedded into a broader integrated transformation of the health sector, building future-proof systems that deliver equitable, sustainable, and high-quality care for all. Before we get started, it is my great privilege to welcome the Chair of the Commission, Her Excellency Katrín Jakobsdóttir, the former Prime Minister of Iceland, to join us from Iceland this morning. Thank you once again for being with us, Prime Minister, as we have a full program ahead. I will now invite you to introduce our speakers, but before that I would just like to remind everyone that interpretation into the Russian language is also available. Good morning, and
Good morning.
over to you, former Prime Minister.
Good morning, Natasha, and so great to have you with us here today for this very important consultation of the Pan-European Commission for Climate and Health, where we are going to hear from a wide range of health systems leaders and experts. I'm really pleased to kick off this very important session today, focusing on young health professionals, in line with our Commission's commitment towards next generations. So let me begin by introducing Dr. Migle Trumbiskaite. And Migle is a primary care pediatrician from Lithuania and the Vice President of the European Junior Doctors Association. In this consultation, she's bringing the voice of junior doctors to the table, a generation that will experience and have to tackle a far more severe climate-related health impacts throughout their careers. Migle, amid the long working hours and mounting pressures on health workers, from your perspective as an early career doctor, what urgent action should we prioritize to tackle the climate emergency? Migle, the floor is yours.
Thank you very much for introduction and invitation. It's a real honor to speak here today. And I'm speaking on behalf of European Junior Doctors Association. We represent over 300,000 junior doctors across Europe. And as junior doctors, we work at the front line of healthcare delivery. And increasingly, we work at the front line of the climate emergency's impact on health systems, patients, and the workforce itself. So junior doctors across Europe already work in systems shaped by staff shortages, as you said, long and irregular working hours, heavy administrative burden, moral distress. Climate change does not arrive as a separate crisis. It magnifies every existing weakness in our health systems. From the lived experience of postgraduate trainees, we already see, it is already visible that during extreme weather events, we see sudden surges in emergency admissions, often without surge staffing or adapted protocols. Hospital infrastructure, diagnostics, and supply chains are disrupted. forcing doctors to deliver care under unsafe conditions. Changing disease patterns increase clinical complexity without corresponding updates in training. And increasingly, junior doctors report climate anxiety, the contradiction of treating climate-related illness while working in systems that themselves contribute to significantly emissions. Healthcare systems are therefore both victims of climate change and contributors to it, accounting for around 4.4% of global net emissions. Junior doctors experience this contradiction every day. And from EGD perspective, to answer your question, there are three urgent priorities that address climate action and workforce pressure at the same time. First, climate resilience must be treated as a core workforce and patient safety issue. This means embedding climate preparedness into clinical governance, not leaving it to voluntary sustainability projects. We need facility-level adaptation and mitigation plans, clear protocols for extreme weather, and recognition that protecting staff well-being during climate events is essential to patient safety. For trainees, this reduces unsafe improvisation and moral injury during the crisis. The second is that we must reduce low-value care and redesign clinical pathways. One of the strongest messages from junior doctors is frustration with avoidable low-value care that consumes time, resources, and emissions without improving outcomes. Trainees describe repeating tests because systems do not communicate, unnecessary admissions driven by fragmented primary care, and defensive medicine shaped by pressure rather than evidence. Redesigning pathways with stronger focus on prevention, primary care, and effective digitalization improves working conditions, patient outcomes, and the ecological footprint at the same time. And the third would be that we must prepare and empower the workforce through education and training. Junior doctors want to act, but too often they are not trained, not empowered, and not protected. Planetary health must be integrated across full training continuum with practical competencies, not just theory. Sustainability and quality improvement work must be recognized as legitimate professional activity, not unpaid extras done after night shifts. Taken together, these changes require a cultural transformation in how we define good care, professional responsibility, and leadership within the health workforce.
Thank you so much, Mikle, for these very important points. And, you know, in the end of your talk, you highlighted the need for cultural transformation within the health workforce to be able to respond to climate emergency. So could you elaborate a little on that and what concrete steps we can make to make this shift really a reality?
Well, for young doctors, this cultural change is not abstract. It means moving away from culture of exhaustion, hierarchy, silent endurance towards one based on quality, trust, and shared responsibility. This shift would include patient-centered, high-quality care, including the courage to reduce low-value interventions, as I mentioned, environmental sustainability as part of clinical excellence, aligned with our ethical duty, that is, do no harm, flatten hierarchies where trainees can raise risks, innovate, and contribute solutions safely, and clear recognition that workforce well-being is a system outcome, not an individual resilience problem. So young doctors are also very clear about what enables this shift, and we need climate resilience embedded into clinical standards, accreditation, and guidance, because when something is measured, then it becomes the real data. We need carbon footprint assessments at system and facility level linked to concrete reduction strategies, of course. We need leadership training and coaching to change communication and decision-making models. And we need to protect it, paid time for quality improvement and sustainability work with meaningful trainee involvement in the design and solutions. So cultural change happens when systems reward the right behaviors, not when they rely on individual sacrifice. And junior doctors are asking for coherence between what we know about climate change, what we teach, how we organize care, and how we treat the workforce. If we build climate-ready health systems that protect patients, reduce waste, and support healthcare workers, then we address multiple crises at once.
Thank you so much, Mikle, for these very important words. I know all the commissioners have been listening and structural change is needed. But now, over to Natasha to introduce our first panel.
Thank you, Katrine. And in our first panel, we will hear from two countries that have both developed and implemented comprehensive climate strategies for their healthcare sectors, yet through very different approaches. First, the Netherlands Green Deal for Sustainable Healthcare is an example from a decentralized, largely private health system, and here climate action is driven through a voluntary collaborative approach initiated by stakeholders and supported by government. Then the net zero strategy of England's National Health Service, a contrasting example from a centralized public health system where climate action is legally mandated. The strategy has just completed its first 5-year implementation phase, and this offers valuable lessons on governance and accountability. But these models are not prescriptive given the diversity of health systems across our region, but they are evidence-backed examples that provide different and valuable entry points and lessons. Together they show there is no one-size-fits-all approach to embedding climate and sustainability into health systems, but that every system can find a pathway that works. And as the first speaker of this panel, it is my pleasure to introduce Ipe van Strooijen, the Coordinator for Sustainability and Health at the Ministry of Health, Welfare and Sport in the Netherlands. Good morning. So how has the Netherlands, through the Green Deal Sustainable Care 3.0, fostered this collaborative and bottom-up approach that sets ambitious sector-wide goals and empowers healthcare actors to take climate action? The floor is yours, Ipe.
Good morning. Thank you, Mrs. Azzopardi-Muscat, for your question, and thank you for the invitation to share with you and the Commission some of our insights on the approach to decarbonizing our healthcare system. As you already mentioned, one of the important things I would like to highlight is the bottom-up approach of our approach. In this, our national Dutch government invited any group of parties in any economic sector to set up a coalition in order to jointly work on economic sustainability. It's the initiating parties themselves then that define the topic of the Green Deal and its contents, both in terms of goals and the ambitions, but also as example for the barriers that should be tackled or the opportunities that should be further developed. Another aspect is also the the fact that the Green Deal is not legally binding. This was something you mentioned already. However, parties do commit to reaching the goals and to the achieving the agreement, and they do so publicly. And we think this public commitment has, of course, some binding effect to achieving the results. We're now 10 years down the road with this Green Deal approach, especially for the healthcare sector, which was initiated in 2015, initiated by a few healthcare suppliers themselves. Since then, both the Green Deal in the contents as well as the number of participants has evolved gradually. Now we're in the third phase of our Green Deal, which was signed in 2022. And this one sets out very clear goals, fitting the back then most recent insight in national and international policy developments and of course on climate change. I'm very happy that now we have over 650 parties in the Netherlands that's joined and publicly committed themselves to achieving the goals of this Green Deal. Now, how does this work in reality is that it is some sort of a complex cooperation between the entire healthcare sector with all the parties involved, the Ministry of Health and other relevant ministries. Try to show you a bit of how this current ecosystem looks like for us. And in this, there's both some sort of a vertical and a horizontal interplay at stake. This horizontal interplay is between the national governments, which includes us as a Ministry of Health, and the healthcare sector. For it still means that we need each other in order to book results and to make progress on achieving the goal for the Green Deal. Then, of course, in our decentralized healthcare system, as you mentioned already, we as a Ministry of Health, we don't have the competencies to actually prescribe to the healthcare sector how to deliver their healthcare and sort of know how to do that in a sustainable way, which makes it a bit more of an effort. Also, other ministries may have some competencies, and especially on climate health in general, climate policy. But what we see is that they often lack, of course, sufficient knowledge on how our healthcare sector is working and specialties that are involved. And which also means then that the implication of general climate policy might sometimes be unknown to the government parties that set them out. Likewise, the healthcare sector is in need of support in order to make the transition towards more sustainability. And this can either be financial support or support policy or regulation, or a combination of those, of course. Then there's also this vertical interplay I mentioned. And this is where bottom-up initiatives, knowledge, or energy that is already available in the healthcare sector often drive the actual transition, especially once they're picked up by the national or at the national level, either by nationally operating healthcare parties or by the government, because something of a good example is promoted to something that should be done by more parties. So in this cooperation and a continuous dialogue between all these parties and stakeholders is key to greening our healthcare sector and to reaching the Green Deal goals. So one thing we learned when we were evaluating the second Green Deal is that formulating and stipulating very clear and especially quite smart goals and targets are quite helpful, even if they might be a little bit too ambitious maybe, or even if it is uncertain if you would be able to reach them. It helps because it gives direction and it sets out a sort of roadmap for individual healthcare suppliers and other stakeholders involved. What we hear a lot now is that individual healthcare providers have sustainability policies in place, pretty much copy-pasting goals and targets from the National Green Deal. Along the way, we also learned that monitoring progress on this sustainability agenda is actually quite challenging. In our decentralized system, it requires agreements on what indicators to use, and of course also on what data to use to get information on the indicators. And it turns out it's quite a puzzle to actually obtain then the useful data and hence generate insights on progress. We are a bit more successful in monitoring the total footprint of the Dutch healthcare sector. The previous presenter also mentioned the importance of it. And now we're very looking forward to a new and more refined results of this measurement, which is to be expected later this year. Last, and I would say maybe most important lesson we learned is to use and embrace already existing energy, inspiration, and clinical leadership in the healthcare sector itself. I dare to say that no other economic sector has such a strong inherent motivation to tackle climate change, simply because it's affecting health. And there's probably no policy model that has such a powerful driving force to battle climate change. Thank you.
Thank you so much, Upe. Thank you for sharing this example and highlighting the importance of local health sector leadership in Netherlands' new Green Deal. And thank you also for being on time, because that's very important when we are having so many speakers here. But this was a really good example. But now we would like to put the spotlight on the Erasmus University Medical Center as the largest university hospital to understand how this looks in practice. Nicole Hunfield works at Erasmus MC as an ICU pharmacist and as the Chief Sustainability Officer. And Nicole, how has the Erasmus University Medical Center turned the Green Deal into real change on the ground, and what concrete successes, like measurable reductions or innovative practices, show its impact?
Yes, thank you for this nice question, and good morning and good afternoon to you all. It's an honor to show you what we have achieved at Erasmus University Medical Center regarding our National Green Deal for Sustainable Healthcare. As Ipe van Steen just showed you, the National Green Deal is of great importance because it gives us, as healthcare professionals, guidance for action. This slide shows our footprint. It's the footprint of Erasmus Medical Center in 2019. And the part in light blue shows our Scope 3 impact. And Scope 3 involves all the greenhouse gas emissions of all the goods that we buy and use as healthcare professionals. And we were quite shocked that medication, shown in dark blue on the left of the middle, was the largest part of our footprint. And why is this important? This whole analysis and having your own footprint as healthcare professional in your hospital, it resulted in action. It was considered a call to action to all of our departments, and it made us move from awareness to mitigation. And the strategy that we use in hospital is a top-down and bottom-up approach. On the left, you can see the top-down items. It's from embedding sustainability in a hospital-wide strategy, also really with focus of the executive board member that's involved, from also reporting to the European CSRD. This stands for Corporate Sustainability Reporting Directive. Hospitals are not obliged yet, but we think that this helps us in planning our next steps. On the right, you see the bottom-up approach. We already have 56 green teams in our hospital, and they are supported by our program. There's a toolkit that they can use. There's a green dashboard, and we also have 40 labs that joined the international greening program LEAF. LEAF stands for Laboratory Efficiency Assessment Framework. And to give you an example of our dashboard that green teams use, this graph shows the amount of gloves being used by my intensive care unit. And what we have is also data showing the total number used over a certain year, together with costs, CO2 emissions, and the number used per patient day. Green teams use this dashboard to measure the impact of their own green interventions, and it's data-driven. Our intensive care unit was one of the first departments that started with the green team, and we always do this data-driven. The poster on the right shows what we achieved from 2019 when we started to 2023. With our green team and with the whole ICU, we significantly lowered the amount of gloves used, absorption pad used, gowns, pupil lights, and intravenous paracetamol. And I can tell you, I just finished the analysis over 2025, and the trend downwards is still there. This shows that we can make a lot of impact with our ICU green team and all the people working in the ICU. And one of the co-benefits is that it also saves a lot of money. And often people ask me, do you think this has a negative impact on the quality of care? And I can tell you that we are analyzing this at the moment, and the first impression is that there's no impact at all, so which is also a very good sign. If you look at the paracetamol use, we started a challenge because many doctors are used to use this in an intravenous form. But if you switch to tablets, you can lower the footprint significantly. It's cheaper, less waste, and it also saves nurses a lot of time. So it's a win-win-win intervention. With this in mind, we started a challenge, and if a hospital succeeds in using 25% less paracetamol, they get this huge tablet shown in the picture, and with this tablet they can make a movie for social media with the hospital's logo on the tablet. So far, more than 20 hospitals already joined in the Netherlands. The amount is growing. We even have a waiting list, and it's all based on an open invitation to join via social media. Also, France and Curaçao already joined, and it's so easy that many healthcare professionals and also junior doctors really like to join the challenge. This brings me to the summary. Environmental data are really crucial in greening your hospital. It results in mitigation. The bottom-up meets top-down approach is very successful in our large academic center. There are many win-win-win opportunities, and our target for the 55 degrees in greenhouse gas emissions in 2030 is possible. We are on the right track to achieve this. So feel free to reach out if you have any questions, and thank you for your attention.
Thank you, Nicole. And we will be able to ask some questions after all our panelists have spoken here. But these are two very interesting examples from the Netherlands. But now we will move on to the UK. The National Health Service England became the first healthcare system in the world in 2020 to commit to becoming net zero. Unlike the Netherlands, it's a centralized public healthcare system which delivers 1.7 million patient interactions every day. So it's a pleasure to have Chris Gormley with us, Chief Sustainability Officer at NHS England. Chris, the floor is yours.
Thank you. Thank you for inviting me here, and good morning, good afternoon, everybody. Yes, I'm Chris Gormley. I'm the Chief Sustainability Officer for the NHS in England, and I run a small team called the Greener NHS team in the NHS. We just heard a little bit about scale there of the NHS. It's a fairly significant entity. Yes, 1.7 million patient interactions every day. We have a workforce of 1.5 million. We have an energy bill of roughly £1.5 billion every year, and probably the second biggest fleet still, I think, in the UK. So we're fairly significant entity, and with that, we know the emissions profile that comes with that is fairly significant. We think we're approximately 4% of England's total emissions. Because of that, we in the NHS believed it was time in 2020 to take that action. We became the first health system to commit to net zero. And what that meant as part of our strategy, the report that we published, the Delivering a Net Zero NHS, was that we really committed to two core targets. The first one being that for those emissions we could control, our direct emissions, we would reach net zero by 2040. And for those that we could influence, we would reach net zero by 2045. Alongside that report in 2022, we also saw primary legislation introduced for the NHS in England through our Health and Care Act. That introduced new duties for all NHS organisations. So for all our 212 trusts, our integrated care boards, our 40 or so integrated care boards. And what that legislation introduced was that they all had to have regard and consider climate impact and environmental impact as part of the decisions that they made. What did that translate into in practice? Well, now every trust, every integrated care board in England has what we refer to as a green plan. And that green plan really sets out how at local level and how across those 1,000 or so hospitals and healthcare facilities, they're going to align with those targets that we've set at a national level. There are also various other requirements in those green plans. It means that every board across all those organisations has to have an executive lead to drive the change at their local level. So that's our governance structure of how we set out nationally and locally. But crucially, how have we done over these last 5 years? Well, we do measure our emissions every year. We publish that as part of our annual report for the NHS. But last year we published our first 5-year progress report. And I guess the overall most important number as part of that report is that we've seen our carbon footprint reduced by 14%. And that's really significant. That's flying 1 million, that's the equivalent carbon of flying 1 million people from London to New York every year. So it's a significant achievement, one that we're proud of, especially given the context of the previous 5 years. How have we done that? Well, yes, there are national and legal targets, but actually how we've really achieved that is partnering key partners across different areas. it's also really down to the passion of our staff. Those 1.5 million people in our workforce. We know that 9 in 10 people across the NHS want to make a difference on climate change and want to take action. So that's where we see the real action and the real delivery. But if I was to take just 2 or 3 parts of our footprint, if we think about medicines, we know that emissions from inhalers, anesthetic gases, including nitrous oxide, really are a significant part of our carbon footprint, 20% indeed, we estimate in the NHS. And we've seen real reductions over the last year through partnership. We partnered with our Royal College of Anaesthetists to almost eliminate the use of desflurane entirely. We've provided incentives and new guidance through our National Institute for Clinical Excellence, NICE, to recommend how we can use lower carbon inhalers and make the switch. We've really focused on nitrous oxide waste, which again brings clinical benefits as well as financial benefits and efficiencies as well. So big progress on those areas where we believe that we've reduced our emissions by almost a third over the last 5 years. Our estate is a big part of our emissions profile. I talked about the 1.5 billion energy bill. We have a really complex estate in the NHS. Some of our buildings are several hundred years old. They're incredibly leaky. So we've really had to partner with government and an entity now called Great British Energy to deliver lots of different measures across putting solar on all our on many of our hospital buildings, really decarbonising heat. We've had £1.5 billion worth of investment through our public sector decarbonisation scheme, we also probably worth mentioning our fleet. It's probably one of the areas that we've learned has actually been quite hard to decarbonise given increased activity. But actually there's a real switch and a transition point in our fleet where we're starting to see a shift to low carbon, zero emission vehicles. We're the first health system, we believe, in the world to introduce a net zero specialist double crewed ambulance. We hope to have 80 of those on the road by the end of this year. What we really need to do is provide the infrastructure for those emergency vehicles to be charging at high rates. So real progress across those areas. I'll probably just finish with one final point. Suppliers, we just heard about it. It's a big part of our footprint. We introduced our supplier roadmap in 2021, which sets out a really clear roadmap for our suppliers to align to our net zero targets, and that has been really an incredible vehicle to bring suppliers along with us in our journey. So just very finally, a big thank you as well to the WHO. I think it's at COP in Belém, guidance on how health systems can monitor and track their own carbon footprints as published, and also how they can take steps on their supplier side as well. So a huge thank you to the WHO in pushing that agenda forward with us. Thank you very much.
Thank you, Chris. Thank you so much. And while the transition in NHS England is legally mandated, it could not succeed without dedicated clinical leadership. And Dr. Mark Harbour is the Special Advisor on Healthcare Sustainability and Climate Change at the Royal College of Physicians.
Thank you very much for the invite and introduction. Yes, I'm a nephrologist by training and work at University College London, but I'm also special advisor to the RCP. So really just the background to this is that in 2023, the Royal College of Physicians did a consultation of its over 40,000 members. That's both in the UK and globally across multiple medical specialties. And they and really said what matters to them, what are their key priorities. And it was very clear that the climate crisis was a major concern. And in this survey and a subsequent survey last year, it showed that 75% of members were really worried about the health impact of the climate impact of healthcare. So there's as has already been mentioned, a real desire to improve things. This resulted in a creation of my current role, an advisory group, the funding for educational fellow, and a commitment also to reduce the carbon footprint of the Royal College of Physicians as an institution. And the key outputs were really tools to help physicians adopt more sustainable practice, education, and advocacy, so lobbying and so on. So as been mentioned before, the feedback from physicians, they don't really know what to do. Everyone's kind of very anxious about this, wants to do the right thing, hates seeing bad practice and wasteful practice in the NHS, and wants to do something. So part of the way of addressing this was the Green Physician Toolkit, published in 2024, which had practical information for physicians. So it was a kind of entry-level guide on what you could do. Some of this was very generic. This has been updated in December 2025 as multiple specialities involved in this, and they really putting more information about the argument about climate change and healthcare, the interaction, also lots of recommendations in terms of how you can switch to lower carbon dioxide medication has been touched on. So IV to oral, liquid to oral has a huge impact, and how you might do that, reducing transport, resilience planning, as well as showcasing lots and lots of proven QI projects. I think that's been really helpful. The RCP is also linked to an organization called the Getting It Right First Time, which is an organization that recommends best care pathways in terms of safety, efficiency, improving clinical care benefit, which is great, but they're now building sustainability into these pathways too. Educational Fellow, we've done lots of kind of podcasts and webinars and social media and publications. Again, really trying to change the narrative on this by essentially this is a social movement, and the more information we can get out there, the more this seems normal. The RCP has also been lobbying, which I can go into later if that's helpful, and looking at ways to be more sustainable as an organization. So I mean, that's a run through a lot of things that are happening. Really, the recommendations for the Commission from the RCP, if I'm allowed, are it is clear, as been said already, that clinicians feel under extreme pressure to deliver clinical care in every health service and do it properly, and don't really have the time, energy, or authority to change practice, and highlighted the need for greater support. So one of the recommendations is that governments and healthcare organizations, if they're not already doing this, need to embed sustainability as a core component in clinical practice. So it's that's a must-have. We need to find a way of doing that. They need to allocate dedicated time resources in clinical job plans, rather than just saying, can people do this in their spare time? And build education on climate crisis and sustainability into undergraduate and postgraduate medication. I would just add a sort of on a broader level, it seems to me that central government needs to have a massive focus on prevention to change the climate and narrative on this, because this is much better medicine, it's much better economics, and it's much, much greener. And I think we've probably been a bit slow in the UK about this, and I can't speak for the rest of Europe, but prevention is definitely the way forward if we want to be greener, but we'd be doing it for lots of other reasons if there wasn't a climate crisis. And finally, I think the other thing that's difficult is that if you're asking individuals from the bottom down to change things, I can tell you it's really difficult. And actually there needs to be central government and healthcare organizations mandating bundles of sustainability interventions. And there are lots and lots of these interventions that have already been mentioned, save huge amounts of money. They're greener, and they often have patient benefit and staff benefit. And we're missing out if this isn't cut and pasted very widely and mandated where it has benefit. And I can give you many examples of that, but I'm over my 5 minutes, so I'm going to stop there.
Thank you so much, Mark, and thank you all for being on time and sharing with us these amazing examples. I would now like to open the floor to commissioners for questions, and we have here Migle, Ipe, Nicole, Chris, and Mark all ready to take your questions. I can see Connie Hedegaard has already raised her hand. So Connie, please, the floor is yours.
Yes, thank you very much, Catherine, and thank you for excellent introductions. Mark Haber just said that the difficulty of having the time and the energy and the resources to do what we all know should be done And I understand the point on having sort of prevention and national governments to be strongly involved here. But my question is for Nicole Hundfeld, because I saw that her specific examples of what they had done at the hospital, including on paracetamol and medication, is extremely interesting. But Nicole, could you expand a bit sort of on the time it took, the payback times also, because some kind of investment has to be done in education or also in direct investments. And a follow-up question to that, we heard earlier on in a previous hearing about steel and steel equipment being a one-time use. And that was seen as a big issue. And could you maybe tell us whether that is also one of your focal points at Erasmus?
Before you answer, I would like to take two questions together because we have so many questions, and I will ask also the panelists to be very concise in their answers. But we will have Connie's question and Omnia.
Yes, thank you so much, Prime Minister. My question is to Chris around the cost savings that the NHS has seen from the diversity of sustainability interventions implemented, especially after you did the 5-year review. And how does the NHS integrate climate adaptation practices? Is it a separate agency? Is it integrated within Greener NHS? Curious to know about that. Thank you.
Thank you. And now I will pass the floor to the panelists. Maybe first, Connie Hedegaard's question to Nicole, please.
Yes, thank you. I think regarding the investments, we see two things happening. If it's an investment that requires change of the building, then yes, we need, of course, money for that. But we take already environmental savings into account, so we make new business cases in that sense, and they're very positive so far. And the other thing is everything we do as a green team saves money. So that what the healthcare professionals can do, they don't need a lot of money. In my hospital, we don't get even time assigned, but we save a lot of money by stopping using things that we don't need. And regarding the steel question, we switched to steel because it was cheaper, and now we're switching back. Yes, that requires some investment, and we need to have a discussion with the sterilization department, but they're quite willing to help us out because many doctors feel sorry that they need to throw away metal after maybe 2 seconds of use, only to cut something. So this is changing, and to be honest, we're changing back to the 90s there. But that's for the planet. That's good.
Okay, 90s, a great decade. But Omnia's question was was for Chris, I believe, and concerning the NHS.
Yes, thanks, Omnia. I think there were two elements to the question. So firstly on savings. So we're at a point now, 5 years on, where actually we can really start to have some really clear savings figures in some areas, probably less clear on others. But to give a bit of a flavour from our progress report, we know that given the energy intensity of our hospitals, things like implementing solar or other renewable energy sources are a no-brainer. We estimate that so taking one hospital, Castle Hill Hospital in Hull, in the northeast of England, £250,000 a month saved on their energy bills from installing a 5 megawatt solar farm. Most other healthcare hospitals and facilities will probably pay back 3 times over if they install those kind of measures. On our fleet, we estimate that if we fully electrified our fleet, we would save £270 million a year in healthcare costs. £60 million of that would be could be reinvested as cashable savings each year as well. On a slightly smaller scale, but nitrous oxide, it requires much less of an investment. But just reducing waste, we know that we're going to be saving £4.5 million every year. by taking action there. So we do start to have these numbers where I think our next challenge is really to think about some of the clinical interventions that we've talked about as well, and how some of our reduce and reuse interventions are actually going to save money globally across the NHS, not just in all the individual circumstances we see them taken in different healthcare settings. So that's our next challenge, but we estimate it's clearly in the multiple millions. We hope to have better figures on that over the next year or so, but it's a significant financial saving across all parts of net zero intervention. On the adaptation side, as part of green plans that we talked about earlier, we're now asking all of our health NHS organisations to undertake a climate change risk assessment. That's the first time we've asked them to do that, but we're hoping to do that as within the next year, that we'll see those returns and those completed. I think it's fair to say that we've very much focused on decarbonisation as part of the Greener NHS team, but we see very strong correlation between adaptation and mitigation in terms of the benefits and potential savings. So we work very closely with our UK Health Security Agency as well, to really understand what changes we're going to make as part of those risk assessments.
Thank you. We have quite a lot of questions, so I will ask everybody to be very concise. And the next two questions, first, Katuna, please.
Thank you, Prime Minister, and many thanks to all speakers for their really very interesting experience and sharing this experience and information with us. So my question would be to EP. I'm sorry if I'm if it's the correct pronunciation. So it was really impressive that all this is done on not legally binding approach. You have this not non-legally binding approach, and that you have such a good progress. So my question would be, why this works? Do these engaged parties get some benefits? Do they have some incentives? Because it needs quite a lot resources, time, the human resources, financial resources, etc., etc. So why it works? It's just about awareness that they have, that a good understanding that they should do something, or there's some other reasons, because it would be really interesting to get this information before. So there were lots of talks about savings, but this is a later stage. And before we get to some savings, why it works? Thank you.
Thank you, Katuna. And before Ipe answers, I will pass the floor to Ernst, who also has a question. Ernst.
Thank you very much, Prime Minister, and thanks to speaker for beautiful presentations. So we heard both from Nicole as well as from Chris about the importance and the major impact of medication, and we heard some examples of shifting, for instance, from IV to oral, etc. My question is to Nicole and or Chris, what else should we eventually as a commission recommend? Because there may be many other measures needed, whether it's to pharmaceutical industry, to regulators, to a European Medicine Agency, etc., about, for instance, opportunities for redistribution, or about packaging, or etc. And a second question, which we don't have the answer now, but might be helpful for us as a commission afterwards from the individual presenters, is what do you think is the targets that you can achieve, whether it's bottom up and legally binding or not, in the coming years? We heard from Nicole about 55% reduction in greenhouse gases by 2030. We heard from Chris the 15% in 5 years, but targeting towards 100% in the next 20 years, which means you have to further accelerate. So what do you think we can achieve in 2030, 35, 40, 45? Thank you.
Thank you so much, Ernst. And then I will pass the floor to Ipe, who Katuna's question was pointed to, and Nicola and Chris, you can answer Ernst's question. But Ipe.
Yes, thank you, Katuna, for your wonderful question. Why does it work? Well, In all honesty, that's a good question, and something for something which can we call a bottom up a black box maybe. But I think there's three things that help in this progress of the Green Deal. One, and by far the most driving force, is what I already mentioned, is this energy in the healthcare sector and the profound drive for healthcare professionals themselves to do no harm. I think it was our first speaker to mention it exactly that way. So we've seen in this 15 years that it was mostly the professionals themselves and healthcare suppliers themselves that were really pushing for the case, putting on the agenda the case of climate and health, and also greening the healthcare system. With that, then there was a second element. It found momentum. It found momentum in the right period, where climate change also on the political agenda grew in attention. We had, of course, the Paris Agreement, and we had a Dutch coalition government as well, aiming for climate change policies, and also a former health minister driving for climate change in the healthcare sector. So this was, I think, a kind of multiplying effect on that case. And thirdly, especially now, costs were already mentioned. So regardless of that, a growing number of healthcare suppliers are aware of costs, and if not for cost, then also for two other things. I'm losing the word for it, but the availability of affordable energy and also affordable materials to be able to deliver healthcare, which in the near future will be more costly and scarce. But maybe also most importantly, the laborship or employership role you have. They also see and hear that young professionals want to work with organizations that have a focus and agenda for topics like these, like climate change and health. So in this, especially in the Netherlands, scarce labor market challenge, this is also something that helps for them to make use of it. So I think this triple or four combination of things, it's a combination that makes it work to do and reach goals, even if it's not legally bound. Thank you.
Thank you so much. And then we go to Ernst's question. Nicole or Chris might answer that, or both. Nicole, please.
Yes, thank you. I can comment on that. I think from industry perspective, we need data. We need data about the footprint of a certain drug. At the moment, we have no ID. We do the calculations ourselves, but we need the industry there to help us out, because then you can make a proper choice. The other thing is that we need to be keen on guidelines. If you have the options to treat a patient with tablets, then I think that is always the first choice. Sometimes intravenous is necessary, but right now we're not very keen on that and we leave it open. I think this can be a bit more strict.
Chris, do you want to comment on that also?
Yes, I'll be brief. Opportunities, we talked about CSRD, and we also have the supplier roadmap for the NHS as well. A significant part of our emissions, as we've discussed, are obviously part of our supply chain. I think really focusing on that. We just talked about a standard. We introduced the first standard for footprinting pharmaceuticals a couple of months ago through BSI, which is a first, I think. So there are some tools out there. I think we have to align them, as we just talked about. And also, if we're going to think about it in terms of demand side as well as supply side, we need to focus on probably 10 to 12 core products, which we can all get behind, rather than there are too many products out there to do it quickly for everything. So we really need to focus on those high emission areas universally, I think, to be able to make the biggest difference. There's also a question about targets very quickly. I think we do have other interim targets as well, which I didn't get into, but the question about whether how difficult it's going to be to meet those, I would say very difficult. We look at our 2032 target in the NHS, which is an interim target, and we see our progress to date really starting to narrow, and it just becomes a lot harder as you start to reach those last part, and we really need to think about innovation and research to be able to really hit those future targets. Thank you.
Thank you so much, Chris. And now we move on to Enrico. Please.
Good morning,
Enrico.
good afternoon, everybody, and thank you very much, Prime Minister, for organizing this great consultation. I have a question about the education of doctors, and especially young doctors, as we heard before. As you know, there is a European Association of Universities which highlighted the importance of focusing their activities on climate change related issues. So there are two questions in this respect. First, is there any European-wide program of training for young doctors that can be eventually used to pass on messages related to our forthcoming report, and in general, training on climate change related diseases and treatments and so on? And if not, do you think that it could be useful that our recommendations address this issue? For example, proposing the development of MOOCs or e-learning courses that could reach out not only young doctors, but especially young doctors through education programs and post education courses. Thank you.
A very good question to Migle. Were you thinking about Enrico? Yeah. Okay, Migle, are you there?
Yes, but eventually also other.
But also other panelists, if you care to comment. But Migle, please.
Yes, thank you very much for the question. I would say from my perspective, I wouldn't know if these kind of trainings exist. And knowing that I communicated daily with European junior doctors from 25 different countries in Europe, maybe they exist, but they are not on our radar that as much as it should be. And what we actually get from junior doctors across Europe is that the training is insufficient and it's not done in a very clear pathway with clear coordination, communication, clear protocols, dialogues, and stuff like that. So to answer that, it would be very valuable if we would concentrate on education, concentrate on training programs for junior doctors especially. Why I'm saying especially and why I'm probably here in this panel today is because this is the future of our medical workforce. So maybe there is lack of motivation and initiative from senior physicians, and that is completely understandable, knowing how much experience and education they have already received. But for the future medical workforce, it's important to be prepared. And as I said, the moment when junior doctor realizes that they are unprepared and they do not know how to deal with changing climate implications on healthcare, on patients, and on themselves, then they have increased anxiety. And they are more likely to even leave the medical workforce as a profession. So I think that's another big problem that we have to address with education and with the training programs that you just suggested.
Thank you. Thank you. We have some more questions, and Sir Andrew, you are next.
Well, thanks, and thanks for all the speakers for the great presentations. I wanted to ask two quick questions, really. One first was to Nicole. You mentioned the aim to implement the circular economy by 2030. And I wondered to what extent you have sort of guidance and metrics for measuring what you mean by circular economy, and also for avoiding unintended adverse consequences. I was reading the other day that plastic recycling, for example, is a major source of microplastics. And so although the concept for circular economy, of course, is a great one, one really have to be careful that we're not causing unintended adverse consequences from increased recycling and reuse and so on. So that's one question. The second, I was going to ask about the supply chains because I think there are major methodological challenges for measuring the carbon footprint of supply chains. I sat next to a senior executive of a pharmaceutical company a year or so back, and I said, well, how many suppliers do you have? And he said, oh, 55,000. So I said, well, how do you know what their carbon footprint is? He said, well, we don't. We have kind of some broad guidelines. So I suppose it's partly for Chris, but it could be for others. How do we actually get better quality data on the carbon footprint of supply chains, given these really serious methodological challenges? My final quick question is about food. Food is 25% of greenhouse gas emissions. The National Health Service, I was at my local hospital recently. The canteen, frankly, was disappointing. A lot of it was ultra-processed food and so on. How can we use the kind of food supply in hospitals and health facilities to actually implement a lower environmental footprint and healthier dietary choices? Thank you.
Thank you, Andy. You actually posed 3 questions, so I'm going to let the panelists have some time to answer before we move on to the next question. You're just making a very good use of your time. But you mentioned Nicole, but also Mark and Chris. So Nicole, please, maybe if you care to comment first.
Yes, and thank you. And thank you for the question. I use circularity a lot because it creates a common language amongst the healthcare professionals. So we talk about reduce, refuse, recycle. And all the nurses in my department know exactly after 5 years what I mean by that. So our goal is to become a circular intensive care unit. It's not easy to measure, but we are pretty much into research, also as my favorite hobby. So we are going to discuss this week, to be honest, with the company to see if we can come up with a framework to do the maths on it. It's new, but I think coming up with a footprint is not enough anymore. I cannot convince the nurses if I tell them a CO2 number, they need more. So my belief is in the circularity language and system. And I think regarding the microplastics, yes, it is an issue. Also the whole greenwashing thing and also numbers that are being reported by companies. It's not easy to know what exactly they are reporting. Not many people can do this at the moment. So we have an issue there that needs to be addressed. I don't have the, let's say, solution at the moment, but I know it happens and we need to be very keen on it.
Yeah, and I think this is actually one of the big questions that we're always kind of tackling within the Commission. Ipe, do you want to comment on Sir Andrew's question? Yes, please.
If I may, so it's on the second part of the question Sir Andrew Haynes posed on the supply chain. It just made me think that actually on this, well, at least for the Netherlands, but I can imagine it's more for more European countries, that this is really something where Europe as an entity, and especially the European Union, is what we need, because most of the supply chain or suppliers of products that are being used in healthcare sector, they are either European or globally operating businesses and enterprises. What we would need is in this level playing field that we have in Europe and in the European markets and etc. So we should find ways, or we are looking for ways maybe together to see how this level playing field on regulations, for example, on information on your supply chain impact, or I forgot the words you were using. So this is really something we need. If we would do it in our country at some point, we might actually take the risk that some of these supply chain suppliers would say, well, thank you, great idea, but your market is too small. So especially for us as a small country, and I'm sure there's a little more in Europe, we really need the joint forces in the European Union or broader European region to set standards, set regulations on providing this information, because I think it is needed to scale up the targets and to see how we can get further.
Thank you, Ipe. I have some more questions coming, but I wanted to ask either Mark or Chris to comment also on the suppliers issue.
I can very briefly. So I recognise the issue. We have 80,000 suppliers in the NHS, but actually the top 2,000 probably account for about 90% of our emissions, or we calculate the top 2,000 to account for 90% of emissions. So it's really, firstly, about focus, but also giving a really clear message to industry and our suppliers about what we expect over time. So we introduced our supplier roadmap in 2021, and there's a series of milestones up until 2028. And I think so in 2027 we'll expect our suppliers to produce carbon reduction plans. From 2028, it's some of that slightly more difficult question about life cycle assessments, and I think we're going to have to really focus again on certain areas. So as part of our progress report, we talked about focusing on medicines, medtech, and digital, and maybe picking certain products out of those sectors to be able to do full life cycle assessments and to assess the benefits. So there are models out there in other countries like Norway, Australia, Ireland, others starting to adopt similar supplier roadmaps.
I did not hear anyone comment on the ultra-processed food. Does anybody want to? Did you maybe, Nicole?
Yes, in the Netherlands, we're shifting to 80% plant-based. That's part of a Green Deal. That's not an easy one. We are at the moment doing 60% in my hospital. We're moving towards the 80, but there are very good business cases out there, and it is possible. It's also better for people. It's better for ourselves. It takes some time, but I think this is an easy one, to be honest, with a lot of examples already in the United States, for instance.
Yeah, and Mark, finally.
Yeah, just to echo that. I mean, I think there's a huge missed opportunity in the healthcare profession. The benefits of a diet that happens to be greener but much healthier, we've kind of failed to deliver on. And there are, as you say, good examples in New York where they've done this in hospitals. But the knowledge, I think, amongst the medical profession is really pretty poor on this front, and there's enormous potential for saying we've got 1.5 million employees, we should be telling them the health benefits of doing this, and by the way, it's much greener. So a huge opportunity. I think we're miles behind where we should be as a medical profession.
Thank you. And I have a final question coming from Karl Lauterbach. Karl, please, the floor is yours.
Thank you, Prime Minister, for providing us with this opportunity, and thank you to the panelists for this important and wonderful discussion. I have a more general question and a recommendation to make. So recommendation to start is, I think it would be very worthwhile if you were to publish your results, as a matter of fact, because it appears to be the case that your efforts to some degree are cost saving from the perspective of the healthcare system. And this is not what people do assume, at least here in Germany. If you think about climate change and healthcare, it is considered to be a trade-off between higher costs on the one hand and cutting emissions on the other hand, but that it may be a win-win perspective in a situation where costs are becoming ever more important. Is important to know, and to publish such results would be helpful for all of us, as a matter of fact, in particular for those countries that haven't started yet, because it is more difficult to embark on new climate change initiatives nowadays than it was, for example, 5 years ago, with, let's say, the political changes that we all see across all of Europe. Number two, I think my question is, do you think that your work in one way or another does have impact in society from a more broader perspective? For example, does the word get spread that this works, and do, for example, the employees in the healthcare system communicate about the opportunities of this win-win opportunity that I have just described? So is this having an impact on the perspective, on the potential of, let's say, climate saving investments in the population in general? And are physicians and nurses and healthcare workers, are they a good means in order to get, let's say, a motivation in the population going to identify with the goals of climate change?
Thank you, Carl. It's a very important question. How much effect actually can the health sector have on society as a whole by doing what you're doing? And also a very good suggestion coming from Carl to publish your results. But which panelist wants to comment on the broader effect on society?
I don't have any scientific base for the following I'm about to say, but I think there is and could be a broader societal effect for greening the healthcare system. And for one, that is just the fact that there's so many people, unfortunately, that are in use of healthcare, but then if they're in the right position, in the right place, they then are confronted, so to say, with greener issues or greener initiatives and greener policy. Which could inspire them or that could tickle them to take this idea at home, in combination with especially the notion that this is also for the good cause for their health and future health. I think is something that would really relate to most people. Having said that, of course, that when most people are in health, they are not maybe very much preoccupied with anything else but then their own health. But I think this is something that could help. On the other aspect, also I think why this is helpful is that what we see, and I hope Ms. Nicole Hunfeld can coincide with that, there's quite some people in their daily days or at home in their personal situation that are surprised and also a bit angry with amounts of medication or amounts with personal healthcare stuff that are prescribed but don't end up being used. And it frustrates them because they also then think, what a waste of money, what a waste of product, what a waste of things. So indeed, I think there is quite some positive impact to be made, broader than just for health, for climate change.
Thank you, Ipe. And Mark, you also want to join us for this question.
Thank you very much. I mean, I feel very strongly about this. I think we have a moral responsibility to give both our staff and our patients actually positive things that they can do and to celebrate the things that are happening. Otherwise, we've talked before about how morale is very low. And I think patients actually would feel very positive about saying, well, we're doing this and this because it's greener and it's better. And there are lots and lots of things that we could do that mean that they can take this home to their families and tell them about things they're doing at work. And as you implied, 1.1 million staff in the NHS, they have their own families and their own communities. So it's a really good place to start, but we need to be probably better at celebrating this and saying why we're doing it and why it's important. And the good news is, as has been said several times before, most of this saves money, has much better healthcare outcomes. So that's a pretty good place to start, it seems to me.
Thank you, Mark. I think we have gone through all the questions, and thank you for very concise and concrete answers and great interventions before that. So thank you all. This has been very inspiring, and I know we will have a lot of food for thought for the final steps of our work in the Pan-European Commission on Climate and Health. But now we will move on to a 5-minute break. Mobility break or coffee break, whatever you choose, and come again after 5 minutes. Thank you.
Welcome back to this consultation of the Pan-European Commission on Climate and Health, focusing today on health systems. So in our first panel, we had this exciting discussion. Many key questions were raised. And one of the topics that was raised was actually around supply chains. And our next panel puts a spotlight on innovative health systems solutions that actually begins with actions along the healthcare supply chain, as we know that this accounts for an enormous amount of overall health sector emissions. 79% across OECD countries, with a significant share coming from the pharmaceutical supply chain. Developing, piloting and scaling solutions to make healthcare supply chains more climate resilient and environmentally sustainable demands collaboration across a broad spectrum of stakeholders. And this commitment is central to the work of the Sustainable Healthcare Coalition, whose Executive Director, Dr. Fiona Adshead, is with us today. Thank you for joining us, Fiona. And could you explain how strategic procurement can help to transform health systems to achieve sustainability and advance climate resilience in the health sector across Europe? The floor is yours, Fiona.
Thank you very much. And you're absolutely right. Sustainable procurement can have a huge role. Overall, if you look at the spending of healthcare systems, about 10% of it is through what it procures. And so therefore, it's really important that we think about how we shape the market, both in terms of how we involve all the system players, because it's a whole system problem, climate change. So we need to work in partnership. Second, how we set consistent metrics, so we're clear about what we want to achieve with those players. And third, we really need to think about how we incentivize shifts towards sustainability by really valuing environment. So if I take the first of those, partnership, it's really important that we include everybody. So the suppliers, the policymakers, but also clinicians, because they understand where innovations can happen. And we heard in the last section just how important that is, for example, at a hospital level. We also need to do this because it allows us to understand how we can tackle practical problems, what they are, to look for solutions and to have a dialogue that really helps us understand and look for innovation as well as insights for the challenges and opportunities for change. And if we're really going to make this work, in partnerships, we need to have clear roles, we need to think about shared objectives, and we really need to think about how we practically implement it. And we heard the last session about lots of opportunities, for example, at a national level with our roadmap in the UK, in England. We also heard about hospital level initiatives, but you can also have shared approaches, for example, with take back schemes, where you're really looking with industry at how you can incentivize that. Or we can learn from industry themselves because they are managing their complex supply chains and achieving reductions not only in environment but also in cost. So there are lots of opportunities. But in the last session, we also heard something very important about the fact that metrics, how we measure things, how we understand value, is absolutely central. And for me, this is a really key issue now. Chris mentioned the fact that the British Standards Institute has produced a global standard. France, Spain, other countries are also producing measures of measuring impact, carbon impact of medicines. And we need across Europe to have harmonized approaches, not only in the metrics we use and the methods we get to develop them. This is really critical because if we're going to really manage that supply chain, we need to really have a level playing field for commercial entities to work on, whether it's in medicines or devices, and it's getting really critical now. I think that the Commission and WHO has a key role to play here because there's a great opportunity for WHO to harmonise and standardise measures and to work across Europe to really make that effective, because I think that will make a big difference. We also know that if we do that, we will really be able to identify opportunities for innovation. And within our own work at the Sustainable Healthcare Coalition, we've really looked at opportunities within care pathways. So we know that investment up front in, for example, preventative measures can save a lot of carbon across the care pathway, the patient's journey in care. We know that's also true for early diagnostics. And interestingly, we've been doing some case studies recently where more traditional implants in surgery, actually, although they may be more environmentally expensive up front because the materials used, over the long run can save environmental impact because you need less surgical revisions, for example. So we need to understand and measure impact. Finally, I think if we're really going to incentivize change in the system, we need to send some really strong signals that this matters to the market. So we need to think about how we're sending the message that we need to put environment at the center of value. So traditionally, how we've done that in healthcare systems in the last 10, 20 years is thinking about health technology assessment, defining what matters in terms of outcome. We tend to focus on cost effectiveness, but we really need to include environment as part of quality. And if we're going to do that effectively, we need to think about the impact not only for individual products, but also across the whole system. Because as I explained, if you're looking at prevention, you need to understand the impact of that product or that device over its lifetime and over the whole system. If we do that by including environment in value in health technology and other critical and structured decision making, we'll send a market signal about market access, but we'll also send a very important signal for when drugs are being developed, because we know at the development stage you can actually design out a lot of impact. So the sooner we get market signals that show that it matters about environment, the better it will be. So that's really the sum of what I wanted to talk about, that we need to act across the whole system. We need to be clear about metrics, and it's very timely right now for the Commission to recommend that we need to work across the care pathway, the whole system, if we're really going to realise and measure impact. And finally, we need to think about value, because essentially what this is critically about is being sustainable by design. We need to have the mindset that that's important, and we need to place the system rules in place so that we can really drive that change and demonstrate through measuring impact that we're making wise choices based on environment, because it's not going to happen by chance. So really realizing the full potential of procurement is about being sustainable by design. Thank you very much.
Thank you so much, Fiona. A lot of interesting points there, and I'm sure we will have more questions concerning metrics and value during our discussion here later. But now we move on to pharmaceuticals, because within global and national health care supply chains, pharmaceuticals have a significant environmental footprint, making it a critical area of action. And to explore this further, I am very pleased to introduce our next panelist, Dr. Kirsty Reid, who is the Director of Science Policy at the European Federation of Pharmaceutical Industries and Associations. Kirsty, how is EFPIA driving climate action within the pharmaceutical sector and fostering partnerships to accelerate progress? Please, the floor is yours.
Thank you so much, and thank you, Madam Chair, and thank you also to the Pan-European Commission for this opportunity to discuss this extremely important topic with you today. I represent EFPIA, which is the European Federation of Pharmaceutical Industries and Associations, which brings together the research-based innovative pharmaceutical companies which are operating across Europe. Now, our mission is to enable discovery, development, and access to medicines that improve and save lives. And that mission is increasingly requiring us to address the climate change as a core health system risk. As has been highlighted also in today's discussions, is really that that climate is no longer a future concern for health systems. It is already affecting patients, health, supply chains, infrastructure, resilience, and also the public health outcomes. And for our sector, the challenge is clear. We must decarbonize while continuing to ensure uninterrupted access to medicines. Now at EFPIA, the climate action is embedded in how we work with our members. We focus on 4 pillars of work. So that includes PI, which is the pharmaceuticals in the environment, cutting across water. It includes chemical actions, circular economy, and also specific focus on climate actions. And we work across with our members, for example, on various initiatives of sharing experiences and case studies, also looking at public-private partnerships, as is highlighted in the slide that's in front of you, and also the gathering of data and various assessments with our companies. A key tool of underpinning this work is EFPIA's regular climate survey, and which allows us to track the progress and also identify gaps and increase transparency across our sector. And the latest 2025 analysis has shown that there is a clear acceleration in commitment and action today. So today, during this session, this is the first time that we are referencing the outcome of the most recent survey we have conducted with our companies. And this detail will be part of a report which will be published during Q1 of this year. So to continue with the discussion of today and what we've seen in the outcomes of our assessments, we would like to bring to your attention some various important aspects that we have identified. One of them really is being that of the looking at the progress that we have seen. So first of all, engagement is growing, specifically in participation of these surveys that we do with our members. We have seen 18 companies in our previous participation of the survey in 2020, now raising to 28 in 2025. And this growth, we feel, reflects a sector-wide recognition that climate change or climate actions is now strategically part of the operations of our companies. Now, let's give you some real evidence. So we've seen some real emissions reductions being achieved. So between 2019 and 2024, where we've been assessing our companies, we see an average Scope 1 emissions fall of about 18%, with several companies achieving reductions of 1/3 or up to 1/2. With Scope 2, emissions dropped by 64% on average, largely driven by the rapid uptake of renewable electricity. Combining Scope 1 and Scope 2 emissions intensity fell from 21 to 14.5%. Now, if we exclude companies who are part of FPA who have also chemical production activities, this intensity drops to 10.5%. Let's look at net zero commitments. So these are becoming more of the norm rather than the exception within our companies. And we see that there are 68% of the FPA innovative pharma companies have committed to some form of net zero. This is really up from 61% 5 years ago. Now, around 90% of these commitments are aligned with the Science Based Targets initiative, and this really reinforces the credibility and comparability. However, challenges remain, and we acknowledge that. So specifically with Scope 3 emissions, and these really dominate the pharmaceutical footprint. And this was even highlighted during the question raised by Sir Andrew Haynes in the earlier session. Similarly, while carbon footprint or life cycle assessments are advancing, maturity varies. Just over half of the companies are at a mid or advanced stage, and they may remain in early phases. This highlights the need for common standards, shared data, and regulatory coherence. What we'd like to also bring to your attention is the need for partnerships. And really, this builds on what Fiona was saying. The pharmaceutical sector cannot deliver climate resilient health systems in isolation. Meaningful progress depends really on a coordinated system across the regulators, the health authorities, the payers, the healthcare providers, industry, academia, civil society. And we have seen that really in our partnerships under the Innovative Health Initiative, like the Premier project looking at active pharmaceutical ingredients. In the environment, Pharos is a project that will launch this year, focusing on PFAS emissions, and Encore and Pharmica focus on safe and sustainable by design. Now, just to finish off, even though there's so much more to really say, it's about what can we bring as something and a way to move forward. So climate policy, I would say, and health policy must be really integrated. Measures designed to reduce environmental impact must also consider medicines availability, affordability, and supply security. These objectives are complementary and not competing, and this has also been highlighted by other speakers today. It is also important for us to find opportunities for shared infrastructure for evidence-based decision-making. I would like to thank you for this opportunity to bring you some of these insights of the pharma industry, and I look forward to the panel discussion later today.
Thank you so much. Thank you so much, Kirsty. And I am sure that there will be a lot of questions concerning your very interesting intervention. However, now we move on. One key strategy for improving the efficient and low carbon use of medical supplies within healthcare operation is the digitalization of care pathways. And we are delighted to introduce Professor Johan van Eltere, Secretary General, European University Hospital Alliance, as our next speaker. The Alliance brings together leading university hospitals to advance innovation in healthcare delivery. Johan, how can actually university hospitals leverage innovation and digital strategies to drive health system transformation that is both future-proof, climate resilient, and sustainable in the face of multiple threats? Please, the floor is yours.
Thank you, Madam Chairman, and thanks to the Commission for inviting me. As you mentioned, EUHA is an alliance of 11 of the largest university hospitals in Europe, including, for example, MC Erasmus in Rotterdam and many others. So clearly, the role of university hospitals is doing research, and by doing research, innovating healthcare, but also training healthcare providers of the future. And as such, we do realize that we play a very important role in this transition to a climate neutral healthcare situation. We are already doing a lot of things in different fields. For example, we are setting up studies whereby through digital acquisition of data directly from the electronic health record, we try to identify low value care and implement low value care. We have written a position paper about preventive care, moving care out of the hospitals into the community and to prevent people from needing to come to the hospital, which we think is also going to be very important, and in which, of course, digitalization will play a very important role. But I'm not going to hide from you that at this moment, hospitals are confronted with many different challenges. Just to name a few, the workforce, which we have the impression now there's a temporary reprieve, but also resilience, cybersecurity, and not to forget limited budgets. And just to make this a little bit more real, 5 years ago, Ernst Kuipers, when he was still CEO of Erasmus Medical Center, proposed to make climate a priority for EUHA. That really didn't meet with a lot of enthusiasm at that time. And since then, I have an impression that it's not really that important for most of our hospitals. So I think a first message, and a very important message, is that we should try to put climate again as a priority on the to-do list of hospitals. And I think that can be done only not by making climate a separate issue on itself, but to make it a part of every decision that is taken in a hospital. And that relates as well to clinical governance, to innovation, to hospital design, to procurement. So clearly, digitalization can play an important role in this. We are experimenting with lots of digitalization, and again, a lot of it is meant to prevent people from needing to come to the hospital, and wearables, for example, are going to play an important role, but digitalization, and especially the European health data space, will also allow us to compare much better data coming from different hospitals, and as such to benchmark clinical pathways between different hospitals and to de-implement low-value care, or on the other hand, increase the efficiency. Of course, one of the big issues in this is that the implementation of digitalization and digital platforms that would allow us to do this still will need a lot of work. And there's an enormous difference between the levels of digitalization in different countries. So there needs to be a big effort to increase the levels of digitalization across Europe to allow these European data platforms to become fully operational and interoperable. Another issue that we are confronted with is wearables. Wearables, meaning, for example, the iWatches that will check how much you sleep, how much you walk, maybe in the future, even your blood pressure and your glucose levels. The data coming from these wearables will be extremely important in the future to prevent people from becoming ill, from linking chronic illnesses to lifestyle. These data for the moment are not part of the electronic health record, and we've already made a plea to the European Commission to make the data from these wearables a part of the electronic health record, because they will be needed if we want to use digitalization to prevent people from needing to come to the hospital. And a third remark that I would like to make is this: artificial intelligence is increasingly used in our hospitals to increase efficiency logistically, but also clinically. We all, on the other hand, know that artificial intelligence has a large carbon footprint. So we would really like to have more data on what the carbon footprint of AI is, and to see whether the use of AI and the efficiency that is meant to devolve from using AI really translates into a smaller carbon footprint. So my recommendations would be that what we really need is action at European level. We need European health data space. We need European data platforms that will allow us to share best practices, to see how digitalization, how artificial intelligence can improve the efficiency, can prevent people from needing to come to the hospital. And to make, in general, these data more valuable for clinical research and clinical governance. This, I think, would be my main recommendation. And the second recommendation, again, would be to make climate not a separate issue, but to fit it in with all the other priorities that hospitals at this moment are considering, and to make it a part of almost every decision that is taken within the hospital context. Thank you.
Thank you so much, Johan. Thank you for very clear thoughts and recommendations, which we will talk more about later. But now, building on the focus of digitalization, our next speaker will take a deeper dive into artificial intelligence as a core component of broader digital strategies for health system transformation. So let me introduce Dr. Miklos Zotzka, Director of the Health Services Management Training Center at the Semmelweis University in Budapest. Miklos, what are the challenges and opportunities AI-enabled health systems offer for climate resilience and resource-optimized healthcare services? And just to move on directly from our last speaker, the carbon footprint of AI, how much does that weigh when we are aiming for net zero health sector? Please, the floor is yours.
Yeah, thank you very much. And thanks for the invitation and for the important initiative and the consultation. And, you know, I spent a life in managing sustainable change. And you know, don't mix my bluntness with pessimism. You know, what I think we need action now. We have been talking about this sustainability issue for so long. Yeah, the early 2000s, the European has prepared to network. We're already talking about zero emission hospitals and the coordination for European investments for sustainability and all that stuff. And you know, politicians are still building hospital totems. And you know, but AI is really a game changer. You know, because if we use data, then one of the major promises is the system optimization, including patient pathway optimization in hospitals and throughout healthcare systems. And reflecting on Professor Elder's sort of contribution, we have to say that there is a broad range of digitization in Europe. For example, what is fax machines in Germany on health data? In Hungary, we have a joint national e-health platform, and I have all my health data in my pocket. So in Hungary, the problem is not the lack of information, but too much information. And you know what Professor Elder said, that there are studies on optimization on healthcare. We can do much more. For example, from the patient pathway, we have already, and I'm sure that in many of the academic hospitals in Europe, have proof of concepts that we can use has patient pathway information for precision prediction. And we can use patient pathway information and digitize an AI diagnostics information for therapeutical predictions, to use the pharmaceuticals more efficiently, that we should not use inefficient pharmaceuticals on patients. And the issue is the access to data. So I fully agree that we need a European health data space, but I think we need much more. We need a European health application space, because all those studies and proof of concepts enable us that, for example, the online economy ready nations like Estonia or Hungary, we have even online cash registers or online invoice registers. So we could identify whether an ultra-processed food is sold to catering in hospitals and all that stuff. So what I think is that we should not do our AI developments in pigeonholes. Yes, we are doing colorectal cancer pathology algorithms. And if we can fuse it with genomic data, we can not only diagnose what's on the pathological tissue, but we can tell the insurer and tell the clinician what is the first choice of therapy in that type of cancer. So what I think is that we should coordinate our efforts. And yes, AI is not green. The data centers need power plants. But I think this is because each and every clinical center wants to be the leader in one of the modalities. No. We should coordinate. I do colorectal cancer, and Professor Eldoret does cervical cancer. And then we just share the application, and we do not just individually pay ChatGPT licenses and fuel the data colonialization of the data-rich Europe by these giants, but we develop a health application space in Europe where we just allow trustworthy AI to be accessed by all actors who contributed. So this is. Sorry, I'm just talking about in a little bit in a fragmented way because I only have 6 minutes. But what I'm saying, we need joint data sets. We need coordinated action to develop applications on it. We have to share those applications. We have to invest in it. And once we have the data and evidence, what would be a sustainable patient pathway, we not only use that data for coordinating investments, at least on national or European level, but we should also use that patient pathway information to signal clinicians and signal patients, now you have to go to the doctor, and the doctor should recognize that there's a too long patient pathway in cancer care, so they do not catch the patient in an early stage. So I mean coordinated action, strategic investment, and using the data as evidence. Thank you very much for the invitation and the opportunity.
Thank you so much, Miklos. And now there is time for questions from the commissioners. Thank you to all of our panelists. A lot of interesting thoughts and questions after this panel. But the floor is open for our commissioners. I would like to start because you mentioned, Johan, that everything we are carrying, I while you were talking, I looked at my phone and I could see that I had taken so many steps yesterday. But then I think about the European regulation on data protection. How can we somehow combine the privacy of the individual and then using our health data to actually be able to prevent diseases? So what are your thoughts on that? And then I have some more hands raised with questions. But please, Johan, if you could react to that.
Yeah. So first and above all, I think it is vitally important that these data about our daily lifestyle are part of the electronic health record, because, as you mentioned, they will enable us in the future to predict who's going to become ill, but also when a patient with a chronic disease needs to come to the hospital, or on the other hand, doesn't need to come to the hospital. So that would be a massive gain in efficiency at the hospital level. What we also very strongly advocate for is that the electronic health record remains a responsibility of the hospital, that the hospital or the healthcare provider is the custodian of these data, which is also, in fact, what GDPR is talking about. We do not believe in national registries where data, parallel national registries where data, be it from wearables or be it from specific diseases, are in parallel collected and then made accessible to whoever wants to look at it. So I think by linking those data from wearables about lifestyle to the electronic health record and making them part of the electronic health record would completely coincide with what GDPR asks us to do. And again, I think, you know, the healthcare provider systems have an ethical obligation towards their patients to treat these data as they should be treated under GDPR.
Thank you. Thank you. Really thought-provoking, I think. Omnia, you are next with your question and comments.
Yes, thank you, Prime Minister. My question is to Christy, and it's actually because Fiona was saying that it is important to send signals to the market, especially when drugs are being developed, because then there's a potential of doing that emission reduction very early on from a pharmaceutical supplier perspective. So I'm curious to know, does Christy agree to that, or has seen that from that side, you know, from the pharmaceutical industry side of this happening in practice, or would also recommend other areas during that drug development phase?
Kirsty, please.
Thank you, and thank you. This is a very important question and one that the industry does take quite seriously. Let me give the example possibly of maybe active pharmaceutical ingredient emissions. And if we look across the whole full life cycle of a medicine, from early research and development through to the manufacturing and the use and the end of life, because those are all important steps and aspects of any pharmaceuticals development, and they generally always include an active pharmaceutical ingredient. So looking at the first stage of the R&D phase, companies we are seeing are increasingly applying what we call the benign by design sort of principles. So this means by considering what is the environmental fate, persistence, what is the level of biodegradability early on in the drug development phase. Okay, and this is done alongside the safety and efficacy as a natural part of the medicine's development. Let's look at manufacturing also. So APIs, the emissions are controlled or considered during the advanced containment and waste handling systems. Also, they have on-site wastewater treatment facilities or pre-treatment before discharge from the manufacturing sites. There's also this continuous monitoring, strict compliance with permit controls. And many companies go beyond also the set requirements. We're starting to see this happening more and more within our companies, where they have internal standards they sort of setting at their global sites, and also with contract manufacturers they work with. Then we look at the supply chain, the big sort of the evil one, where most of the emissions are, and there they're starting to work on having environmental clauses as part of their procurement contracts. They're auditing and capacity building really with the different API manufacturers, including inside and outside the EU. And also we see them engaging more and more with various initiatives like that of the AMR Industry Alliance. And then just quickly on the sort of end of life, also where companies are trying to look into how they can reduce environmental releases. So really about, and this has come up in earlier discussions today, we saw the paracetamol example coming from Nicole from the Erasmus Medical Center. And it's really about how we can work with the healthcare system to help make sure that there's prudent use and prescriptions of medicines, also the safe collection and disposal systems of unused medicines, and also just for information, the pharma industry will need to pay for the quaternary urban wastewater treatment facilities that are set up across Europe in the coming years through a extended producer responsibility system. So we are seeing companies really investing across the whole life cycle in trying to reduce their emissions impact.
Thank you. Thank you so much, Kirsty. Now we have many questions, so I will ask everybody to be very concise. Hans Brunix, I believe you are next. Hans, please.
Yes, thank you. Thank you, Catherine, and thanks for the presentations this morning. Very interesting. I have a question regarding the educational side of this whole undertaking. To what extent is the medical profession, and I look at it broader than just the fundamental education at university level, ready to integrate this fundamentally into their program, their knowledge base? And to what extent does this also get connected to the research funding? That is, because that is really the currency if you look at academia and how important things are regarded. There is an implicit pecking order in the medical profession at university level, and let's say that this type of knowledge is not exactly at the top of the pecking order in many places in the university system. So the question is, to what extent can we improve that? I think this is really central because we are not doing that. I was teaching at the Institute of Tropical Medicine in Antwerp last semester. Young researchers, practitioners, nurses, doctors, they all confirmed that it's only marginally mentioned. It's not at the center of their education, and it's definitely not a smart choice if you want to be regarded as the top guy or woman in the professional context in which you work. So how do we turn that around? A second very small comment is that the medical professionals are regarded as the most trusted people in society, by and large. To what extent can you use that public trust as a sort of leverage point to put this type of knowledge on the agenda? I think there is a big responsibility given the trust that people have in the profession. Thanks.
Thank you, Hans. I suggest that both Johan and Miklos could answer this. So maybe if we begin with Johan and then move on to Miklos, but I must remind everybody to be short and concise.
Well, I think you're absolutely right that it doesn't have the attention it should have. And that is why I think we need to think very hard about a narrative that makes climate part of the whole training, but also of the whole thinking in the hospital. So yes, it could definitely be improved. And I would say that it's the same about prevention. Prevention is probably something with a major impact on public health, and that is also not the best way to be a leader in your field. Prevention is also considered something for the lesser gods. And I would say at the same is true for climate. So it's a narrative that we have to change, and that is absolutely important. As regards the trust that hospitals and healthcare providers in university hospitals still have, I mean, towards the public, that is indeed something we have been thinking on very hard, and it's something we should be using more, especially in view of all the fake news that is being spread to different kinds of media, including social media. It is something that I think we need to take more responsibility in. Thank you.
Thank you. And Miklos, you wanted to add to this?
Yes, we are teaching on sustainability for more than a decade at the university, and in about 5 years ago we started to have an English language course for all the international and Hungarian students, and we were surprised by the rate of attendance to that sustainability course. Also the same issue with the undergraduate course on AI for us, but nobody financed the development of the curriculum, so there were no sources available for that whole thing. So we do it on a voluntary basis. We also developed the master's program for doctors, data scientists, and managers in-house. So we are bringing together the three actors, and this is the second year, and we are running the program with full class. So it is so there's a lot of attention to it, and also but the most interesting initiative that we had is we are doing these idea competitions or hackathons for green hospitals, and the Hungarian Hospital Association teams us up. For example, the pharmaceutical waste was one of the winning ideas in the recent Hospital Association conference, and then there was also energy efficiency stuff. But the issue is that, yeah, fine, okay, we just give the awards for these teams of students or teams of medical residents, but the investment into those initiatives, we are lacking that stuff. So either the research grants or the development or investment grants for sustainability are very scarce and not coordinated and not strategically targeted. Thank you.
Thank you. I think I will pass the floor to Linda next, and straight after her to Ernst. And we take two questions together. So Linda, please.
And thank you to everyone who is trying to sharpen a bit our thoughts, because we're reaching a point at this commission where we are thinking not any longer anymore on the focus on and how climate and health are related, but how to translate that link into some concrete operational policies. So I have one question. So where do you see the main barriers to embedding all the climate risks, or the majority of them, into the hospital safety and preparedness standards? Because hospitals usually follow the money, not the policies. So the differences, or maybe the difficulties, in my opinion, might be in the political caution, into the evidence missing somewhere, or simply into the governance and budgetary line. So what do you think? What are the concrete terms where we can engage ourselves as well to give some concrete proposals?
Thank you, Linda. A really good question. And I will ask the panelists just to raise their digital hand if they want to comment on that, but and make a note of the question. But Ernst, you also have a question.
Yes, thank you very much, Prime Minister, and thanks to the speakers again for excellent presentations. It was impressive, for instance, to hear from Kirsty about the results that the pharmaceutical industry has already achieved. I will look into the white paper. Now, my question goes to Johan. I remember very well the discussion a couple of years ago, not so very long ago, about ÖHA and whether or not climate and climate action should be number one on our agenda at the time. And the fact that this was at that time a little bit too early. I remember it well. Now, the question I have is, you mentioned innovation, including AI. And do you think that it should be possible to actually develop a framework to assess the impact of innovation, including AI and wearables, in terms of greenhouse gas emission, etc.? So do you think that's possible? And you can look at, for instance, the proportion of remote care, the reduction in medication use, the reduction on imaging, the reduction on workforce needed, etc. And if you think it's possible, do you think that ÖHA can take a lead in this? Thank you.
Thank you, Ernst. This was a question for Johan, but first we do Linda's question, how to kind of, and Fiona has raised her hand telling us how to make sure that the hospitals that follow the money implement climate action in their work. Fiona.
To keep it short, I think it's again about the system rules. I think we heard last panel from Mark Harbour. and he made the point very clearly, and it's true from all our studies of care pathways in hospitals, is that people tend to think action on environment is going to increase cost. Most of our findings and case studies is that actually environment not only reduces cost, but it also improves efficiency and can release staff time in terms of productivity. So I think that's why measurement across care pathways is so critical, because then we can understand by design how we can transform services in clinical trials, which we focused on. Again, many companies engage in reducing the impact of their clinical trials because it saves them money as well as having an environmental impact. So we shouldn't think that things that are greener are going to cost us more. They don't necessarily do so.
Thank you so much. Kirsty, did you want to add something short to that?
Very short, yes. Just to also highlight that there's a need for, sometimes regulation can be quite restrictive. So there's a need for regulatory flexibilities in this case also sometimes, but also engaging with the healthcare systems, with the hospitals. Often it's seen that working with industry is often criticized, that we have too much of an influence. What I would like to really say is don't close the door always on any funding opportunities or engagements, projects with the industry. Realize that all stakeholders should be part of the processes in moving forward.
Great. We have also a question here for the FPI. I don't know if you can answer it very shortly, Kirsty, but it's a question from Connie. Does FPI have a data for the development of emissions from the medical sector over the last 20 years? Can you answer that in one sentence?
Can you repeat the question just quickly?
Does EFPAI have data for the development of emissions from the medical sector for the last 20 years?
We have data from 2019 when we started doing surveys across our companies. We have 4 years of different data. And as mentioned, we will be publishing the latest data and the assessment of the last sort of five years very soon.
From 2019. Okay, but Johan, short answer to Ernst, and then we have the last question from Sir Andrew. But Johan, please.
Thank you. Maybe first about what is holding back university hospitals to be more involved and to include climate. Time and money is certainly something, but it's also a cultural change. We are, as university hospitals, very much aiming towards breakthrough in healthcare. We need to also look more at public health, which again, until now was more something for lesser gods. So it's a culture change, and culture changes are not easy to do. Now, as regards Ernst's questions about innovation and the use of AI, is it possible? I think it is possible. And what is even more, I think it's needed, because whether we like it or not, AI is increasingly being used in our hospitals for the moment, mostly in logistical efficiency increasing applications, but slowly also in clinical applications, and it's certainly going to have a major impact. So we absolutely need it. What I think is absolutely essential when we look at AI is that when looking at its impact, we need a system approach. Too often in the past, when we did studies, it was in a very defined and small environment and not taking into account the impact on other places or other activity centers in the hospital or even in the broader community. So we need a kind of different approach from the very controlled studies that we did until now, with a more system approach study to see what the impact is. What could be the role of UR in it? Well, as university hospitals, again, I think we are driving innovation in healthcare. We are also training the healthcare providers of the future. So yes, I think it's our damn duty to be active in this field. We already made a position paper saying rethinking healthcare. We need to, to pay more attention to prevention. And I think climate would nicely fit into this more public health approach that university hospitals need to take. But again, that's a culture change, and culture change are the most difficult to achieve.
Thank you, Johan. And the final short question from Sir Andrew, please.
Okay, thank you, Prime Minister. Yes, just one question. So up to now, really the focus has been on hospitals, but certainly in the UK, 90% of the contacts with the National Health Service occur primary care settings, primary and community care settings. So if you ignore those settings, you lose many, many opportunities to integrate prevention, but also to prevent unnecessary medicalization, unnecessary referrals. So my question is, are the panelists aware of good examples of the integration of primary and secondary care in climate adaptation mitigation actions, and of useful teaching and training materials? I know myself of one or two, but I'd be interested to know from the panelists. Thank you.
Okay, I see a hand raised from Miklos, so maybe you can answer that question, Miklos. And Fiona, but very short, both of you. Miklos, please.
I approach AI as a systems capability. So it is not just a tool on a diagnostic machine, but it is a data agent that is helping the screening, the prevention, the follow-up with the medication of the patient, and signaling the interventions for the patient and for the doctors. So if we have AI as a system capability, then we can also target primary care and precision prevention.
Thank you, Miklos. And Fiona, last answer.
Primary care, very important, Andy. As you know, the Royal College of General Practitioners in the UK has got a brilliant toolkit. We have done a calculator to look at the impact of primary care delivery itself. And there are lots of examples of how digital platforms in supporting communication of patients with their clinicians in hospital and in primary care can reduce admission rates because they get earlier treatment at home, and self-care is obviously a key component of that. So I think a little bit like the initial question on the where we send signals, the more we're saying that we value this and we're important. And finally, I would say that so much of the admissions in healthcare systems are actually driven through primary care. If we think about the role of inhalers, their prescription in primary care is absolutely critical, which is why it's important that we're going to have clear standardized metrics and that clinicians are supported to make choices between different products in a way that enhances health outcomes. Otherwise, they will see a number when we just have product impact. And if they don't think across the system, and they don't think about the value of care, and if they're not supported, it won't work. So primary care is critical, and Andy's absolutely right. There's not enough emphasis on that in the system.
Thank you so much to all of our speakers and panelists for great interventions and answers.
Coming now to our last panel, it actually is building on the last discussion that we have had, because we are going to be talking about solutions that address climate stresses on healthcare services while reducing the environmental impacts across two key areas. The physical healthcare infrastructure, which, as we heard, does not only stay with hospitals, but also encompasses integrated community-based care and primary healthcare. And it is my pleasure to introduce our first speaker for this last panel, Lilian Vidiridi, Secretary General for Health Services at the Ministry of Health in Greece. Thank you, Lilian, for making time to join us. And considering the acute climate impacts Greece is already facing, what are some of the key strategies that the Ministry of Health in Greece is applying to make the health facilities more climate resilient? The floor is yours.
Thank you so much for the chance to be here with you today to discuss such an important matter. And truth is that climate change is no longer a distant possibility, but a real and accelerating challenge with far-reaching impacts on all aspects of daily life. So in the health sector, of course, the challenge is twofold. On the one hand, the health impacts of climate change place increasing pressure on healthcare services and test, of course, the resilience of existing systems. On the other hand, the healthcare sector itself has a substantial environmental footprint, as previous speakers have elaborated upon, given that hospitals and clinics consume large amounts of energy as well as resources, generating significant greenhouse emissions. And of course, something that we shouldn't overlook is that at the same time, it's placing growing pressure on health systems, increasing both the demand for services and of course the risk of disruptions from heat waves, floods, wildfires, and of course the spread of infectious diseases. The health workforce also faces major challenges. I mean, according to the WHO, a global shortage of 18 million workers is expected by 2030 due to climate-related stressors such as extreme heat, mental health strain, burnout during emergencies, which threaten the safety, well-being, and performance of healthcare staff. So this dual challenge makes it essential to develop healthcare systems that are both climate resilient, low carbon, capable of meeting citizens' health needs, while of course minimizing environmental impacts in line with broader EU sustainability and climate objectives. So in practical terms, as already mentioned, it requires infrastructure and services that can withstand climate-related challenges without compromising, of course, quality, safety, or accessibility of care. Turning to Greece, the country has taken important steps to strengthen the resilience and reduce the environmental footprint of its healthcare system. While a fully coordinated national strategy is not yet in place, significant progress has been made through investments in infrastructure designed to be sustainable, resilient, and able to cope with the challenges of climate change. As part of these efforts, 80 hospitals are currently being upgraded with EU funding, mainly through the Partnership Agreement for the Development Framework and the operational program Transport, Environment, and Sustainable Development. So this program, amongst other goals, aims to upgrade public buildings, improving both their structure and energy performance. At the same time, 156 primary healthcare centers are being renovated with support from the Recovery and Resilience Facility. So these healthcare centers are mostly built in the 1980s and now are being upgraded both functionally and energetically to improve resilience, safety, and service quality. So upgrades include better insulation of walls and roofs, replacing windows, upgrading roofs and decks, and partially or fully replacing mechanical and electrical systems, including heating, cooling, and ventilation. Flagship projects in the direction of sustainable development and climate neutrality are the 3 new public hospitals currently being constructed in Greece through a major donation by the Stavros Niarchos Foundation as part of this health initiative. These projects have a budget which exceeds 500 million, and they include the University Pediatric Hospital in Thessaloniki, the General Hospital of Komotini, and the General Hospital of Sparta. Construction is expected to be completed and facilities delivered to the Hellenic state by 2027. Now, from the earliest design stages through construction and future operation, these hospitals fully integrate principles of environmental sustainability. The design, construction, and operation of the hospitals follows the principles of the internationally recognized LEED certification system. For those that are not accustomed, it's leadership in energy environmental design, with the goal of achieving LEED Platinum certification. So all critical parameters have been incorporated, including energy efficiency, water management, indoor air quality, the use of environmentally responsible materials, and sustainable operation practices, many of which are already being implemented during the construction phase. A central objective is for all these 3 new hospitals to be delivered as buildings ready for operation with net zero carbon emissions. Achieving this goal, of course, depends largely on how the facilities are powered and operated, with a strong emphasis on renewable energy sources. For example, at the new General Hospital of Komotini, rooftop photovoltaic systems will cover nearly 20% of the hospital's energy needs, with geothermal energy, which will meet almost all heating and cooling requirements. Importantly, the foundation has signed a memorandum of cooperation with the US Green Building Council, Green Business Certifications, and ARC-SCORU, aiming to pilot a recognition framework for newly constructed buildings designed to operate with zero carbon emissions. So this collective effort brings together all stakeholders involved, from architects to contractors, around a shared climate ambition. One of the most innovative aspects of this project is the strong connection between the hospitals and the natural surroundings, as well as the integration of nature into the healing experience of patients. So a significant number of new trees will be planted, 780 in Thessaloniki, 1,235 in Komotini, and 600 in Sparta. And in addition, the hospitals will be equipped with advanced digital infrastructure supporting paperless operations and integrated systems for sustainable management and maintenance. It will operate, of course, in a fully digital environment for medical, nursing, and administrative services with international HIMSS standards. So in closing, and I leave room for questions, Greece experience shows that climate resilience and low carbon healthcare cannot be achieved in isolation. So real progress depends on collaboration between the public sector, European institutions, private partners, and donations working towards a shared goal.
Thank you so much, Lilian. Thank you for a very interesting intervention. And now we move from Greece to Portugal, and from a national perspective to a local level. With us is Professor Alexandre Lourenco, CEO and Chairman at the local health unit in Coimbra. Alexandre, what climate risks is the local health unit in Coimbra facing, and what are some of the key strategies you are applying to become more climate resilient and environmentally sustainable? Please, the floor is yours.
Good morning, Prime Minister. It's a great pleasure to be with you today. And mostly, let me just share some of the challenges that we have. We are a particular region that is affected by wildfires. Maybe some of you remember that in 2017, more than 100 citizens were killed during wildfires in Portugal. So this is a dramatic situation for all of us. And of course, all our organization is focused in tackling these issues with what we call traditional measures like cycling, reduction of CO2 emissions, and of course, also mostly engaged in the circular economy. From these traditional emissions, it's the change of our fleet to electric vehicles. And we are talking about nearly 100 vehicles that is being changed. Some of the issues that we are also tackling are related with patient transportation optimization. And in this case, we introduced an algorithm that allows us to reduce at least 25% of patient transportation ability due to new algorithms that allow the optimization of each ambulance and patient transportation vehicles. But most of our strategies, besides all this conventional or we would say more green focused, we are also focused in changing the way that we provide care. Usually we believe that, or actually we believe that healthcare needs to address patient needs. And this is also related, of course, with the overall climate crisis. Let me just share with you a sentence from Peter Drucker that is nothing so useless of doing efficiently, something that should not be done at all. And of course, let me give you some, for examples, of the initiatives that we are doing. One of it is the Cascade Alignment in all organization. Our organization, we have a little bit more than 10,000 employees, and we have clear strategic objectives in reducing carbon emissions, reducing or increasing the efficiency of using energy, and also reducing water consumption. These strategic objectives are also transformed in indicators that are cascaded in all organization. So even each professional and related with their career progression, they have at least in 7 indicators. One of it is related with mostly energy efficiency and the reduction of water consumption. Some other examples that I would like also to share is introduction of digital clinical pathways. We are doing this in most of the chronic diseases areas, like diabetes, heart failure, COPD, asthma, depression. And on these digital clinical pathways, we transformed all the clinical pathways in a digital tool where we have all standardized all the transitions of care from primary care to hospital services to long-term care. And our system allows that all healthcare professionals that deal with specific patients have their patient data available. Also, another way of managing these digital clinical pathways is that we focus also on communicating with the patient, and we have a remote monitoring unit that is also communicating with the patients, both with AI, but also when alerts are emitted or are launched, our nurses communicate with the patients, allowing them or mostly focusing on self-care or in the referral to primary care, to the primary care doctor, to the emergency room, or to our hospital clinics. Let me give you an example. In diabetes, it's a complex digital clinical pathway that engages the supports of self-care with this remote monitoring. Also in primary care, mostly focused in family health teams with strategic ophthalmology units in the community, wounds units in the community, and also programs in related with prevention, like the first 1,000 days child obesity program. And of course, at the hospital side, we reorganize the way that we provide care, mostly in creating a diabetics clinic where all medical specialties join together to provide patient-centered care. With this digital tools, we aim, and with the definition of the clinical pathway, we aim to reduce in 50% all A&E episodes and reduce hospitalization by 50% for diabetic patients. Of course, in all of this, let me give you other examples where we are using AI and new ways of providing care in the community. This is a program where we introduced a new clinical pathway that is allowing us to reduce clinical appointments. Of course, also more than 10,000 clinical appointments in ophthalmology. Usually a family doctor refers to the hospital for an ophthalmology appointment. They get first a consultation, the doctor prescribes auxiliary exams, they come to a second ophthalmology appointment for the revision of their exams, and then to book a specific appointment according to the problem of the patient. So what we introduce is 6 ophthalmology units in the community where all patients that are referred, they get an OCT and a retinography. And with an AI tool, we immediately know if the patient is healthy or if he needs to have a really ophthalmology appointment. And in that case, this is always validated remotely by the ophthalmologist, and the patient is directly referred to the subspecialty that like cataract surgery or other areas like diabetic retinopathy. So with this, we reduce immediately, in our case, 10,000 medical appointments per year.
Alexander, we need to wrap up very soon.
I'm finalizing, mostly also giving an example. When we introduce phone triage system for emergency rooms, with increased access in acute care and new acute care centers. And last year, we have a reduction in 50,000 A&I episodes, mostly because we developed this system. So final messages, I believe that rethinking care models is really urgent. Digital tools can strengthen health systems resilience, and proximity care based in community services supports sustainability and rural development. Also, people-centered care enhances sustainability and climate resilience. Thank you.
Thank you so much, Professor Alexandru Lurenko. And we will have time for questions after the last speaker on this panel. Investing in future-ready healthcare facilities involves not only technical considerations, but also thoughtful financial planning. And this has been mentioned here today. The Council of Europe Development Bank finances health infrastructure projects, and I'm very pleased to have Thomas Kirkle with us today, who is a senior technical advisor for health and social care at the bank. Thomas, how does the Council of Europe Development Bank strengthen climate resilient and low carbon healthcare facilities through your social investment projects? Please, the floor is yours.
Thank you, Chair. Indeed, I'm very glad to be with you this morning. I'm working as a technical directorate of the bank in charge of the health portfolio. I'm not a banker, but I indeed work in the bank, and this is indeed where you can follow the money. The bank has been established in Paris 70 years ago. Just in a nutshell, we represent 43 member states, the last one being Ukraine. And we like to call ourselves the social bank of Europe. We're not very big, 250 people working here, but we work across 3 lines of action and several sectors, focus sectors, including education, social housing, and health. And when investing in these sectors, we have 3 cost-cutting teams, which interacts with our priorities. And these, of course, include climate change, along with gender equality or digitalization. So the project we finance should contribute to our priorities that are in our strategic framework. This is very familiar to WHO and member states. It includes high quality, affordable healthcare, and they should address issues such as unequal access, aging population, and climate-related health impacts. So I'm trying to show you here that even if we are not a climate bank, climate mitigation is indeed one of our priorities. We are organized in a way that we have a unit dedicated to environmental and social safeguards. And when it comes to ESS, indeed, the bank uses a framework to ensure that environmental and social risks are identified, assessed, and managed adequately. And you know these risks are linked to healthcare facilities. They include hazardous waste generation. They include untreated or poorly treated wastewater and other issues. So more specifically, the bank sees the climate crisis as a social crisis. I told you in the beginning, we see ourselves as a social bank with a social mandate. And so we understand that this social crisis can threaten social, economic, and territorial cohesion. They exacerbate inequalities and maintain vulnerable people in a cycle of underdevelopment. And so in order to mitigate those threats, in our assessment of hospital projects, of healthcare facilities projects, during appraisal, we will always consider the climate social nexus, mainstreaming climate-related issues in social investments, and integrating a social dimension in climate action. We will ensure that all financing activities are aligned with the Paris Agreement, and we will ensure that we prioritize investments that enhance the climate resilience of vulnerable populations and support a just and inclusive transition to a decarbonized and climate resilient future. So when we speak about the Paris alignment, as you know, the Paris alignment assessment for infrastructure, including healthcare facilities, considers both mitigation and adaptation aspects. So when speaking about mitigation, because healthcare buildings are significantly energy consumers, implementing energy efficiency measures can enhance their operational performance and reduce costs, minimize environmental impacts. So we at the bank, we will encourage efficient HVAC, that reduces energy consumption. We will encourage high-performance insulation that reduces heat loss or gain, reducing HVAC loads. We will support energy efficient equipment acquisition, and we will promote daylight designs in space to maximize natural light. As you know, climate hazards can severely disrupt healthcare facilities, healthcare services, damage infrastructure, and compromise patient safety. So typical examples include river or pluvial floods, windstorms, sea level rise. So because of the likelihood of those climate hazards impacting the healthcare facility's location over its lifetime, we use a geographical climate risk tool. So you may want to ask, how current and future climate risks affect the bankability of a project, of a healthcare project. And to assess this, we use a location risk intelligence software that helps the bank visualize the exposure of the project location to natural hazards. It's a software that assesses climate risk by combining both historical data and future scenario climate projections. And it enables our bank to understand current and future physical climate threat under different scenarios. So if the climate risks are not addressed by the borrower in the project design, we will not consider the project as Paris aligned and therefore not bankable. In these cases, we will work together with the borrower so that the climate risks are addressed and that the bank can go ahead with the financing. And sometimes we would provide technical assistance. When it comes to the second dimension of the Paris alignment, meaning adaptation, as you all understand, healthcare facilities must remain operational during and after extreme weather events. So we would encourage flood resilience design. We would encourage heat wave preparedness, water efficiency measures, and wind resilient construction. If I have a bit of more time, I can give you a few examples.
You really don't, Thomas. You really need you to wrap up now.
I'm wrapping up with two examples.
Yeah.
We just recently approved two operations, one in Leipzig, St. George Hospital, where climate change aspects included a primary energy demand of 16% less compared to the local requirements, hot water production, green rooftop, etc., etc. We also approved an operation in Finland, in Laakso Hospital in Helsinki, with ad hoc geothermal wells. And I could give you other example of Barcelona Sant Pau Hospital or Belgrade, Tiršova Children's Hospital, where those measures are encouraged by our financing. Thank you very much.
Thank you so much, Thomas, for your very interesting intervention. I have already two commissioners asking for the floor. Enrico Giovannini, you are first. Please, the floor is yours.
Thank you very much. Great presentations. I have an education and training related question, because we have been mentioning this issue throughout the morning, and I'm curious to understand whether the hospitals that we heard now in this session have any particular initiative to educate patients during their staying at the hospital and afterwards. Of course, you are getting contact with thousands and thousands of people, especially in some cases waiting for being treated. Maybe I'm referring to the Italian situation, but I think that the situation is similar to other places. It's a great opportunity to educate people about the climate-related issues. So is there any initiative like that we can learn from and eventually recommend?
Thank you, Enrico. A very good question. Alexandre, you want to answer, please?
Yes, we don't have direct programs for inpatients, but as we are responsible also for skill education we have specific programs to increase literacy in climate change and mostly energy efficiency and climate-related issues. So all our school programs led by nurses, they are focused on these kind of areas. At the hospital facilities, mostly what we are engaged is really in the reduction of waste. And in that case, we have programs, for example, for reduction of bottles or plastic bottles and things like that, so at the hospital side. But we don't have any direct program for literacy for inpatients in that case.
Thank you, Alexandre. We have a few minutes for more questions. Omnia, you are next.
Yes, thank you, Prime Minister. My question is to Thomas. And you mentioned the risk tool that you have for healthcare facilities to assess, when a climate-related disaster happens. My question to you, and this was actually my thesis, and I couldn't find the financial instruments available yet. If a hospital gets, if impacted in terms of equipment, damage of infrastructure by climate-related disaster, how can they access finance to be able to recover from these climate hazards?
Thomas, please.
Well, they just need to come and see us. I think, indeed, what we are trying to do is to prevent those situations and to mitigate those risks. So when we grant financing, we really make sure that the designer, the architects, the medical community, and the borrower, which is most of the time either the Ministry of Finance or the hospital itself, will take into account those risks. But if we come after such a disaster, well, it will. I guess we will consider it as lessons learned, and we would see with the local beneficiaries how to make sure that this doesn't happen again. But again, most of the time we would go through intermediaries. It could also be other types of banks to which we lend, and we would take those aspects into account.
Thank you, Thomas. I have one question that could both be for Lilian and Alexandre, which is, the fact that we have been talking about it here, that there is less enthusiasm for climate action, and then we are talking about the population and the politicians. But since you are both living in areas which have been which have been hit drastically by climate change, what is how do you experience the attitude of the population when it comes to climate action? Lilian, please.
Thank you for your question. It's really something that from a government point of view, we're trying to instill as a topic of conversation. I mean, as I mentioned, we do not have a national plan in place, but I think that it's never late to start by small actions, which actually show how important it is for today and for the future. Mm-hmm. I think that as Ministry of Health, we have initiated a conversation on the matter and small actions which we envisage as a government as a whole to put in a national plan, because truth is we cannot do it alone. For example, in Thessaloniki, in the new Stavros Niarchos Foundation, we had to collaborate with the Transport Authority to include strengthening the main bus line serving the hospital in order to reduce the environmental footprint associated with the transportation of patients, visitors, and staff. So as Ministry of Health, yes, we have to work on the way health services are being provided to minimize interaction on the way we build them, but we most certainly cannot do this alone. Mm-hmm. And the more we bring it to the agenda, the more we stress the reasons why we take actions, the more it hinders in the people's minds that this is something we have to look after.
Thank you, Lilian. Alexandre, would you care to comment for 1 minute on this?
No, very, very fast. Thank you. No, I believe that, of course, there is some sort of decoupling between the public policies and the citizens' actions. And in that case, we need to struggle more to mostly convince our citizens of this kind of problems. I believe that everyone is talking about it, but the issue is really what are the actions that are being implemented.
Yeah.
Fast enough?
Well, very fast and also very contentful. So thank you to all our speakers, both on this panel and earlier in the morning. We have actually had a very dynamic agenda during this consultation, featuring insights from 13 outstanding speakers on integrating climate action into the essential transformation of the health sector, building resilient, future-proof systems. Now, as our last speaker for today, I am inviting Dr. Dimitra Panteli from the European Observatory on Health Systems and Policies to share some reflections on today's interventions and how they align with the general transformation that we need in the healthcare center. So, Dimitra, the floor is yours.
Thank you very much, Madam Chairman, Prime Minister. I hope you can hear me well. It's an honor to be part of this event today. It has been really insightful for me. My name is Dimitra Panteli. I lead the work on climate and health at the European Observatory on Health Systems and Policies. We are a partnership hosted by WHO Euro. And our partnership includes international organizations like WHO and the European Commission, but also national and regional governments, payer organizations, academic institutions. So a very multifaceted approach. And I have to say, everything that has been discussed today really aligns with what we've been hearing from our partners over the past couple of years. Also, the key years, let's say, that have put this climate and health agenda onto our agenda in terms of the work that we do. Our mandate, our goal is to be a knowledge broker, bridging between evidence and decision making, so that fits very well with what has been discussed today. I will try to summarize in 5 minutes what I feel have been the key messages that are coming across. There was so much rich content that's actually impossible to do, but I'll try to draw some lines, and I hope I'll keep in time. Otherwise, please feel free to be unkind. I will stop. What we heard very clearly, I think, as a very first starting point throughout the panels, is that yes, and Migla said this morning, health systems are victims and perpetrators in the climate and health relationship. But we also see and understand that adaptation and mitigation go hand in hand, both in terms of the benefits, but also in terms of many of the policies that we need to adopt to address them. So one clear example from one of the last contributions from Lilian is this building renewal, where we both get climate resilience and we get a lower footprint. So we need to think about it a little bit more holistically than the two poles that we sometimes tend to think about. At the observatory, with the, let's say, catalyst of the pandemic, we did a lot of work on health systems resilience, not specific to climate, but to different types of external shocks, with climate and extreme heat events being one of the pilot tests that we did. And increasingly in this thinking, we included into the steps that can be taken, what can we do to also address the issue of mitigation. So that's a very important point. The other point I think that came across very clearly for me was that a lot of the strategies that we need to adopt for more climate resilience and sustainable health systems lead to achievements and to improvements that we've wanted to have from the health system perspective for a long time anyway, for other reasons, for better patient outcomes, for better financial protection, for better responsiveness, like moving more towards prevention, moving more towards primary care, reducing low-value care. So that's really important. On the issue of low-value care, I'll take a footnote here, because we heard from Johan about their initiative at the hospital level. We had at the observatory with the TU Berlin the opportunity a couple of years ago to start with the Health System Performance Assessment Group at the European Commission, work on how to rethink low-value care. And one of the novelties that came out of this work is that we consider very clearly care that has more sustainable alternatives as being low-value care in its own merits. So part of sustainability being a part of value in itself. So this is part also of the narrative that needs to change, as we heard from our speakers throughout the day. I think I'll return to that if I have time at the end, but I think one of the other points that really drove home the message for me today was the need for measurement. Fiona made that very clear, but I think it permeated all of the presentations. We're talking about metrics if we want to change at policy level, embedding sustainability in health technology assessment. We're talking about metrics to communicate with professionals and patients about reshaping patient pathways. We're talking about metrics to make the business case about why actually greener is not just greener, but also more cost effective and perhaps also better for quality of care in other ways. And also, we need to think about it, I think, from a health system perspective, if I bring that part of my work in, as part of what policy needs to do. So in this whole narrative and cultural change, we need and should be thinking about how to integrate sustainability metrics and adaptation metrics into health system performance assessment, which doesn't normally do that at the moment. So that's a very clear point. Now, very briefly, because I know I'm running low on time, a couple of more points. Workforce is the catalyst. I think we heard that very clearly. I think we need to really think about how to include the workforce, not only in the types of strategies that we plan, but also in what education will look like. I think we need to understand, going back to the first presentation of today, that young professionals especially are not just more sensitized to these topics, but are also the people who we are trying to attract to the health system. We talked about workforce shortages. They are more likely to want to work in greener facilities, in more digitally enabled facilities. So that's something that we need to think about also in that perspective, not just how to educate, but also how to leverage that motivation to move forward. I think finally, or this will be final because of time, one of the things that really struck me was that we have a lot of pioneering good examples from a lot of countries in the region, but obviously not from all countries in the region. And what we saw was that we need a combination of top-down and bottom-up. So we need the top-down environment to enable the initiatives that take place at the local level. This will not look the same for other countries in the region as it looks for the Netherlands. So we can look at what others do to have good examples. But what we know at the observatory from a lot of comparative health systems research is that we need to tailor to the needs of the different environments and the different settings. So I think for the Commission, that's something that's really important. A lot of pioneering work and a lot of good examples, but we need to think how we can bring that to the individual member states in a way that's implementable. And this is where, this is a final sentence, collaborative and exchange platforms are really important. We heard that as well throughout the day. And I think structures like the WHO, like the center in Bonn are really important. And I think we at the observatory are willing to help wherever we can add value. Over.
Thank you, Dimitra. Thank you for your very insightful remarks. Now, when we're reaching the end of this consultation of the Pan-European Commission on Climate and Health, Natasha, we're reaching the end. I'm looking forward to hear your thoughts.
Thank you, Chair. And as you know well, the European Programme of Work 2.0 has a fit-for-purpose health systems at its heart. And I believe that what we have heard in the past 3 hours is really about fit-for-purpose health systems. And this builds on the framework for resilient and sustainable health systems, which all 53 countries had agreed to at our regional committee in October 2024, which among the 8 priority action areas includes a strong commitment to environmental sustainability in terms, let's say, of the health sector's own green credentials, and also in contributing to wider efforts to mitigate the health impacts of climate change. And as we heard earlier this morning, it's really, we are perhaps in a very privileged position to communicate with the public, to earn the public's trust, because there is so much at stake for people's health, for older person's health, for example, as we are working now on our older person strategy. But I would like to underline our commitment within the health systems division. We heard very much today about making climate change not something extra, not something that we have to do over and above, but actually each team takes climate change into its own work program. And I think this was a very loud and clear message that we heard from our panelists in the context of the wider political and social environment we are navigating in today. And I would also end by emphasizing the importance of the conversation. Dimitra also made reference to it, where we opened with Migle, because if we are to instigate real change, it must come from those who have a vested interest within the systems themselves, those who have a skill set, those who have the passion, and I can think of no better leaders here than the future health and care workforce itself. Allow me, Prime Minister, to thank everyone who has worked so closely with you, with the Commission, in preparing for this hearing, particularly Sidika Goven and our colleagues from Bonn, and of course David and his team from the studio. What an honor, what a pleasure, what a privilege it was to have this opportunity to moderate this hearing with you, and count on our support to enable the Commission to deliver on its final report, which we are very much looking forward to seeing.
Thank you so much, Natasha, for your kind words. And it's a privilege to be working with the excellent team at WHO Europe, but also with these amazing people in the Commission. I would just like to use my time here when we are reaching the end to thank all the speakers again. It was a very contentful and insightful consultation, and I think you have given us a lot of food for our final steps, because now we have already had 3 hearings. This was and now we have had 3 consultations. So 3 hearings, 3 consultation. A lot of material has been assembled. We have been having dialogue with experts in climate, in health. Those of you who are working within the health sector, we've been talking to politicians, national, local politicians. So I think we have really heard a vast array of opinions, but also a lot of very good examples on what we can do to actually implement positive climate action and also positive health action. So thank you all for participating today. Thank you, Natasha, for your help in organizing this session. And we move on to the final stages of our work. You mentioned the recommendations. We plan to present them in May at the World Health Assembly in Geneva. So until May, the Commission will be diving deep into all the material we have assembled and do what we promised to do, to produce practical and implementable recommendations for local and national policymakers, so we can actually see positive climate and health action. So thank you all, and looking very much forward to the next steps in our very important work. Thank you.